I once had a clinical supervisor who said to me, human beings have the most complicated descriptions for the things they understand the least. So what I'm going to do today is I'm going to try to distill the Medicaid program for you, and hopefully you'll be able to walk out of the session today with a new understanding of how dollars flow, how the safety net is organized, and where there might be some extraordinary opportunities right now. And to ground us for one moment, this presentation is going to be financy, and it's going to get complex at the end. But it should be grounded in a really important reality, which is we are facing a question as a culture. That question is, what will the most prosperous nation in the history of the world do when twice as many of its children try to kill themselves? So for those of you who are working in a local health system or in a safety net child-serving system, if you're thinking, wow, it sure seems like stuff is going on, you're not making it up. I'm going to close with some really difficult epidemiology, but it distills to the fact that the question I just asked: how will we respond as a culture when twice as many of our children kill themselves, try to kill themselves? That's what just happened over the last decade. So hold that while we do the math. While I hope you learned something here, I also want to contextualize my comments. I learned what I'm about to tell you by actually doing it. So it's hard to understand Medicaid finance unless you've had to make payroll. And in my early 20s, I started the first charter school in the state of Pennsylvania. I worked as a therapist in the Oakland Public Schools. I administered FQHCs. I worked in a level 1 pediatric trauma. I have designed, led, worked in Medicaid finance programs in every child-surfing safety net. So I'm trying to distill some complex stuff here, and I think it can be done, as I'll show you in a sec. But also, the lessons that I'm trying to impart have been learned by actually running a program in a direct clinical service setting. So if I spontaneously combust, I want you to be able to add to 1. Okay, that's actually Medicaid, okay, right there. That's all of it. I'll let it sit for a second and stew, right? That's actually how Medicaid works. So let's talk about what those halves are, because the 1 is the dollar we're all seeking, right? And I would also say, for anyone who says it's not about the money, I don't know where you are living. California ranks 42nd in the nation in spending per Medicaid beneficiary. That 1, we rank almost last, despite having the highest tax base in the nation. So the way I describe that 1, or the Medicaid in California, is a Charlie Brown Christmas tree with a bunch of pretty Christmas tree ornaments hanging on it. The pretty ornaments are revenue measures like Prop 63, like Prop 10, like all this stuff that, frankly, elected officials have gotten famous on, but haven't sifted into our Medicaid program. So let's describe what those halves are. 1 half is this the search for that. And that's what you all are actually going to join me in after today. You're all going to be CPE hunters. Because if you have CPE, you get FFP. That's the beauty of Medicaid for kids, and I'll tell you how that works. But CPE is defined as a public, non-federal dollar, not already being used to match a federal dollar. Okay? Now the key is open up your minds and your hearts to what CPE is. It's not just what the state gives you. It can be all kind of stuff. It can be your Maddie fund. When someone speeds through your county and they get a speeding ticket, dollars come to the county. Those dollars are local public dollars. Your county could be super progressive and have passed a 1/2-cent sales tax for healthcare. That money comes into the county. We actually did that. That's a certified public expenditure. So what you should be doing in your counties is looking around for any place I got a dollar that's non-federal, that I control, that's not being used to match. That's CPE. That's the half that you're looking for. Because the FF&P, that's the fancy name for the money that comes from the feds. Federal financial participation. That's the dollar, that's the pot of gold in DC that flows if you got the CPE. I could almost walk away, but I'm not gonna. So CPE plus FF&P equals a Medicaid expenditure. And if I talk too fast, slow me, because that's a problem I got. We should make it into a rap, I just heard. Yes, okay. Okay, but there's a really important thing to understand about that FF&P is that EPS, ooh, I spelled it wrong. Love it. Is an entitlement. So what does an entitlement mean? An entitlement means is if you have the CPE, the FFP has to come. So think about that for a second. That means any dollar you have that you spend to an allowable beneficiary for an allowable service must be matched. The feds cannot say no. That's what an entitlement means. EPSDT is different than the rest of Medicaid for that way, in that reason. Really important. But you have to understand the origin of EPSDT, and the therapist in me says you have to go back to go forward. And I will say I worked for Richard in Alameda County not knowing this story for many, many years. So the origin of EPSDT is fascinating, and it will help you hold and understand why this equation works. Medicaid was created in 1965 in the Social Security Act. Everybody should know that, right? Medicare for the elderly, Medicaid for low-income folks, 1965. What happened in 1965? We had the Vietnam War draft. We drafted hundreds of thousands of mostly low-income men. And guess what? The military rejected half of them, deemed them unfit to serve. So in 1967, the military sponsored an amendment to the Social Security Act of 1965 saying that children in Medicaid have a unique standing and entitlement. And they named that unique standing early periodic screening diagnostic treatment. And they named 7 benefits. The first one is perhaps the most successful experiment in the history of American public health. Immunizations. And I love Dr. Pan's comment this morning, my kids too, immunized on time. Yep. So immunizations, 85% of low-income children get their immunizations. The 7th benefit was mental health. Less than 5% of children in our systems get access to EPSDT-funded mental health. Do you have to have measles to get an MMR shot? Why, oh why, oh why must you have one of 16 diagnostic criteria to get a mental health service? Crazy. So do you got the origin? The military sponsored the thing? So if I spontaneously combust and you remember nothing else, you can think of one of the essential reform that we are about to do. Actually, it's happening right now, is we want mental health to be like an immunization. We shouldn't be looking at 4 to 12, even to 20% of young people getting it, because we know that the number one service most necessary and effective for the healthy development of children is social and emotional development. Because what kills kids? Homicide, suicide, and injury, behavioral conditions. So I want to just give an example of how to use this EPSDT half plus a half, how we did this in one public system. And this example gets often talked about, and I'm not talking about it as a lesson for others, because as I'll tell you at the end, I don't think this can be done elsewhere, which is why we need the reform. So please, this is not like braggadocious. What this is meant to show you is the opportunity we have as a state if we effectively match the dollars we're already spending. In Alameda County, between 2001 in 2014, we added 8,000 children to services in over 200 schools. I know because in 2000, I was working at McClymonds High School in West Oakland. Ooh, yeah. I was a little therapist, newly minted therapist, chasing kids around, learning about the wisdom and intelligence of low-income communities and their ability to thrive and not just survive, but thrive despite these extraordinary challenges they faced. And I was running around, and then this lawsuit happened that added mental health to the EPSTT scope of benefit, and we had this thing called the EPSTT Gold Rush. And I was working in this tough school. We cleaned out an old broom closet. We put a sign on the door that said, "Sanctuary, no school staff, no school police allowed." This was a school with 2 full-time police officers and a half-time school counselor and no school nurse. And we realized that I could get paid $3 a minute. So that was 2000, 2001. I then went to work for the county, and during this period of time, we added over 8,000 children to care in these schools. In 1996, we had 4 of these federally qualified school-based health centers. Tracy Mendez is here from the School Health Alliance. She was working at La Clinica. She started a few of these. In 2000, we had 8. In 2004, we had 12. In 2008, we had 14. In 2010, we had 19. In 2012, we had 26. In 2014, we had 29. I think there's 31 today, maybe. These are federally qualified health centers. They're as nice as where you get your care. They are built with school bond money. 80% of their operations comes through the services they provide. Now, if I had that again, I'd reduce it because our clinics were chasing dollars so much that it became problematic. But at the same time, we also started 200 school-based mental health services in schools. Almost all of these were funded through EPSTT, and remember how EPSTT is funded, remember, right? Half and half? So here comes the harsh part. It took 11 sources of non-federal. So if you look at the middle, that middle pie chart, those on the right-hand side are the list of non-federal sources. Remember, non-federal means CPE. And in the dark blue is the Medicaid match. We had a unique set of circumstances in Alameda County. We had a progressive elected leadership who believed in school health, who gave us access to non-federal resources to claim against. I had mentors in the space, Vanna Chavez and Dave Kears, who taught me how to do this work. And we had a willing set of school district partners who wanted to play and were willing to write school bonds to build clinics in it. So sort of a unique set of circumstances. And over 14 years, we learned some really hard lessons. So I liked hearing today from the 2 counties about the difficulty and the culture of collaboration. I won't go into it, but in almost every school we started a program. 4 months in, a clinician makes a CPS report, the parent shows up with a baseball bat, they have a moment with the principal says, "How come you didn't tell me?" That just happens in every school. The culture is what it is. There's reasons for the laws being the way they are. They have to be negotiated through the process of doing the work. As the Buddhists say, the truth is in the unfolding. There's no shortcut. There's no plan that can be written. You have to do the work. You have to get in it and learn it, piss each other off, and come to work the next morning. But what this process taught me in schools is that the child-serving safety net works the same way across all child-serving systems. So what I'm going to tee up for you right now is a potential multi-billion-dollar revenue strategy that we could generate on what we're already spending. I would argue to you that all of child-serving safety nets, not just schools, work the same way. So go with me for a second. There's a federal action tied to a state commensurate action, but almost all of the child-serving safety net is delivered or organized at the local level. I mean, it certainly was in my county, and I'm pretty sure it is everywhere else. That's true of child welfare. It's true of juvenile justice. It's true of early childhood. It's true of education, and it's true of the regional center. Don't forget the regional center, 1915H, a home and community-based waiver. It's Medicaid, okay? I call those the big 5. And actually, yeah, we could call early childhood a system, but we could debate that, okay? It's a thing. It's a bunch of stuff. What do we know about those systems? They're all serving low-income children. As I'll show you in a moment about the growth in Medicaid, almost all of the children in those systems are eligible for Medicaid. How are we funding those systems? Non-federal dollars, largely. Are we claiming those dollars to Medicaid? No. So for those of you in the county world who also work in the adult side, and remember, Secretary Galley did this initiative. If you know what whole person care was, under the last 1115 waiver, so I'm going to get technical for a second, but for the few who can track me, just go with me for a moment. Under the last 1115 waiver, health systems looked out at the homeless and reentry population, and we said we're spending $1.5 billion on this population. Feds give us a match. 26 counties got $1.5 billion from the feds by federal matching on what they were already spending. Are you with me? What if we did a whole person care for kids at scale on the existing non-federal expenditures already in the system? So if you're tracking me at all, raise your hand. Okay, more than half, we'll take it. But the tie that binds all of these systems, the thing that makes them the same, is children's mental health. So I'll show you how failed our children's mental health system is, and I'm not attacking any mental health system in the room, but I don't know a single elected official, county administrator, or provider who says, oh yeah, we got children's mental health covered, don't worry about that, right? None of us believe we got it covered. But maybe our problem is our solution, because the architecture is already there. Over half of children in child welfare already have an open EPSTT case. Half of the placement costs of a juvenile justice out-of-home placement are covered by EPSTT. Home visiting is covered by MON, TCM, early childhood. About 30% of special education costs are covered by EPSTT Medicaid. And the regional center is already a Medicaid program. So if you went with me for a second and believe, wow, the architecture is already there for systemic reform, the financing opportunity is already there, what if we went for it? So that should tee up a sense of possibility. But now I gotta explain the challenge. Because whoa, if it was only that easy, right? Because Medicaid is not one program. I wish it was. While it has a common architecture, the way to understand Medicaid is a pot of gold sitting in DC, that's that money bag, right? That's that, remember what we called that? FFP, in the money bag. Tied to a state action, let's call it our state Medicaid plan. And then let's put a family and a child down at the bottom. So what I'm gonna do for you right now is show you why it doesn't work. And I'm gonna show you why it doesn't work through the current reality of how that federal dollar gets down to a family and child. The first and biggest way is health plans. Managed care organizations is the technical term. And we've done a massive transition. If you don't know the health plan in your county, you're missing out on the single largest source of funding. In 1996, 85% of Californians were in fee-for-service Medicaid. Today, 85% of Californians are in managed care. In fact, 96% of children now are covered by a health plan with a mental health benefit, but only 5% are getting access. So this is the money bags. This is the nut that must be cracked by child-serving safety nets. So that's the biggest one. That's measured in billions. The next is your county mental health plan. As you may or may not know, in 1984, California carved out mental health from the scope of benefits and gave it to county mental health plans under something called a 1915B waiver. And your mental health plans are your county mental health departments. You with me? Gosh, if it only stopped there, that'd be one big problem, but it gets worse. We also have departments of public health, what are called LGAs, local governmental authorities. This is where your TCM and your MA and your CPSP and your CCS and all of your public health categorical programs are funded out of. You have your school districts and your SELPAs. Mildred Brown is here, a pioneer in vendorizing SELPAs. Ron Powell is here as well. We'll hear more from him. Some do it, some don't. SELPAs and local educational agencies sometimes get vendorized, but as we heard from Dr. Pan this morning, California ranks 40th in the nation in Medicaid spending in schools in absolute numbers. So wait a second, that's not a proportionate number? That's absolute numbers. We should be number one. So being 40th is a horrible, horrible number. We're really bad at it. We have fairly qualified health centers. That happens. You can get services in Medicaid through that. We have our hospital system, largely public health hospitals and UCs, and of course the regional center. So if you're a child or family, your federal dollar gets to you through, let's call them 7 basic ways, right? 7 fundamental ways. And by the way, this is a new PowerPoint slide. I'm testing it out on you. So, but if you're a county health system, you're really focused over here. One, because you either are the system, the mental health plan, where EPSDT is administered, or the managed care organization, which since 2014 has the obligation for the mild to moderate mental health benefit. So these are your two major players, but you have to have peripheral vision because these matter too. Okay? I'm not including, before people quibble too far, I didn't include fee-for-service. There's others I didn't include. But these are the big, for child-serving safety net. If you want to know how Medicaid works, you better have a pretty good sense of these 7. Oh, sorry. Right. That's my big point. Thank you. In yellow underneath these slides, I actually put the claiming methodology. And why that's so important is because a lot of us are involved in this thing called CalAIM, which I'm sure a lot of you have heard about, but there's a fundamental change coming to your county mental health plan. Currently, health plans get paid in capitation, meaning when a health plan receives a dollar, it's already matched. So if I'm a physical health plan, if I'm a managed care organization, when I spend my dollar, it's half federal, half state, right? I don't have to go match it. Man, I have run hospitals, I have run FQHCs, all the places I've worked in. By far, the most complicated and difficult claiming methodology in Medicaid is this one, the County Behavioral Health Cost Report. It's really hard. And what happens in a county, and it's the same way in LEAs, is you fully spend the cost of the service, 100% with non-federal dollars, and then you retroactively claim the federal match per minute, per patient, per diagnosis, with all of the brutal paperwork that entails and the audit risk. It's brutal. It's super brutal. In fact, half of clinicians' times are spent coding, charting, and protecting from the dollars that they've generated. This is no way, got it, thanks. This is no way to claim Medicaid. It's the hardest way. And by the way, CalAIM suggests a change. Woo! Okay. But quickly to name the other ones, Department of Public Health, LJ, MON, TCM is also a CPE methodology. School districts are also CPE. School districts are scared to claim MA because they get their money clawed back. And so that's a culture question between the state and the county. So we sometimes talk about fragmentation across systems, but there's also vertical fragmentation between the state, the county, and the provider. Community health centers are PPS. Hospitals are IGT or P14, and the regional centers are 1915H. It's also a CPE methodology. But the reason I put those on there now is because we are literally looking at a unique moment of fundamental transformation of our claiming methodology in mental health, because we have proposed, and the state has adopted, a proposal in its CalAIM to move from CPE to IGT for behavioral health. So if you're a behavioral health system out here, help is coming, I hope, right? I mean, at least there's an intention for change. So let me put this in the context of the crisis, or the question I posed to you at the beginning. And I'd like to end with some sobering data about why it's so critical we pointed this out. I pointed this slide out to tell you why it's not working, right? Because my task today was to explain to you the Medicaid map to help you understand how federal dollars flow. But I also believe there's a great opportunity, and I showed you the bubble chart to show you that if we claim against what we're already spending, we could generate a new investment. And boy, do we ever need it. There are 6 million children now in Medicaid. That's a 33% increase in the last 5 years. And you may ask, well, how did that happen? Well, first, we rolled in healthy families, S-chip, right? So it used to be Medicaid was 0 to 138% of federal poverty. Now it's 0 to 250. More kids in. The next thing we did, which should be trumpeted from the heavens, I don't understand why we don't all give each other high fives all the time, we covered the undocs. When Tracy and I were working in Oakland, we were always having to fake it. I put a lot of 9999 Social Security numbers, right? And you can audit me if you want. And that was because we couldn't serve kids who didn't have status. Well, now we put every single child under 250% of federal poverty, regardless of immigration status, is now in Medicaid. That is so important. and it's something I'm so proud of to live in this state. And the third thing, yeah, that's a great one. Because remember, 51% of the Medicaid population is brown. 80% are children of color. So now 6 out of 10 kids, 6 out of 10 are not just covered by Medicaid, but covered by a special kind of Medicaid that entitles them under federal law to everything that they should get. So we now, as I mentioned, have 96% of children. So I've worked on a lot of children's coverage initiatives. We can now start talking about, well, what our kids are actually getting. And the reality is kids aren't getting very much. Suicide and inpatient visits for suicide are up 104%. That's that doubling I mentioned. ED visits for impulse control are up 71%. We're now spending over $12 billion. And in California, this is a really important one because it means hospitals are now our partners. Length of stay, meaning butts in beds, days in the hospital, is down 33% for all disease burdens in California. Everybody's spending less time in the hospital, with the exception of pediatric mental health, where they're up 50%. So if you're if you're in a hospital business or in your health plan business, you are now interested in a way you never were before because your utilization is there. And these numbers, unfortunately, are crossing all socioeconomic status. Actually, the most dangerous place to be a young person is to be a rural white kid with a gun. Boy. So as hard as it is to try to reframe it this way, there is a moment where the economic opportunity is overlapping the social justice opportunity, so we got to make hay. It's now, right now. And we have failed to respond to this troubling data. In fact, it's gotten worse over the last 5 years, and I'm about to show you some data that should make you uncomfortable if you're working in a county, and I don't mean to attack anybody. This is the numbers. This is the math. There's been a 33% increase in the number of children in the program. There's actually been a decline in the percentage of those eligible getting access to care despite the acuity and utilization data I just showed you. So more children are eligible for services, yet fewer are getting care. We were already under 5%. And I should note, this number is from the state's performance outcome system. That number just means you touched the system. You could have called access. It doesn't mean you got anything besides got named by the system. That metric, what we call in ongoing care, as measured by 5 or more visits in a calendar year, is actually under 3%. Since 2011 realignment, and I will put 2011 realignment as a line in the sand, but I don't want anyone here to accept a simplistic solution. 2011 realignment did suck. It is a block grant. It does what all block grants always do. Give flexibility to local government and less people get access to care. I mean, Reagan called it devolution. California calls it realignment. The pressures in local safety nets are all about public safety. The district attorney and the sheriff are elected. The health and human service director and the health director are appointed. Look at where the non-federal dollar goes in local safety nets. It's almost 10-to-1 to public safety. And that's not to bash any of my public safety partners. It's because of collective bargaining. It's because you're running correctional facilities. It's really expensive to run a public safety infrastructure. And it sucks resources away from health and human services. And that's just the harsh reality. So what California did in 2011 is it took 5 mental health programs, block granted them, and said to counties, you now have flexibility to spend it as you will. And what happened? There was a 20% increase in crisis service utilization, and the access rate declined from 4.5 to 4.1%. Ouch. And young people are telling us, for those of you who are familiar with the California Healthy Kids Survey, young people are actually self-reporting a 61% increase in mood and anxiety challenges. You know, it's not just showing up in the hospital. Young people are telling us that they're not getting what they need from our public system, and they're showing us in acts of despair. So this is my last slide. I just wanted to flash it up there again. The opportunity before us is fundamental reform of our mental health system on the principles of EPSDT, where we would reinvent mental health, not as a response to pathology, but as a tool for healthy development for all children. Could you envision a world where every young person, as a function of growing up, the same way they get access to immunizations, get access to behavioral health support? not because they're broken, not because they're pathological, but because it's hard to be a young person. Thank you.